convener of Pragmatic Pediatrics from Pioneers Program. Over to you, sir.
Very good evening. Respected State President Dr. Shimmy Paulos, our respected National President, Chief Guest, my close friend Dr. Basavaraj sir, National Secretary Dr. Yogesh, South Zone Vice President Dr. Singaravelu sir, and all other dignitaries, past President Dr. Jose, Dr. Narayanan, Dr. Ramesh, and today's speakers, Dr. Abarna, Dr. Fagan, and also all our dear friends and all office bears of IAP and all delegates from inside and outside Kerala. A warm welcome to this scientific program. It's our idea that to conduct a systematic scientific program once in every 2 weeks and on every Friday at 9 p.m. I congratulate Dr. Jose, Dr. Balendran, and Dr. Narayanan and their team, IAP Kerala, Dr. Krishna Mohan and Dr. Shimmy, for organizing such a wonderful scientific program. I wish the program all success and all the best. And over to Dr. Soumya.
Thank you, sir. Now may I invite Dr. Shimmy Paulos, President IAP Kerala 2024 for the presidential address.
Respected National President Dr. Basavaraj sir, HSG Dr. Yogesh Parekh, our South Zone Vice President Dr. Singaravelu sir, our Education sir, and Dr. Balachandra, my secretary Dr. Krishna Mohan, Ramesh sir, are the immediate past president of National Central IIT. The speakers for the day, Dr. Suman, Dr. Abarna, the moderator, Dr. Abarna, and Dr. Fagun, who will be giving us the talks today. A warm evening to each and every one of you. The idea behind this program was dawned upon our Dr. Jose and Dr. Balachandra and Dr. Education is to get more speakers from outside to update our knowledge on various topics. So in the beginning, when we thought about this idea, it was a bit confusion whether we should go ahead with it, especially when everybody is now off the Zoom platform and everybody is meeting face to face. But when you meet face to face, traveling at this time to get to see a good speaker, hear from them, and get ourselves updated is quite tough. So having such programs in the long run with a lot of topics being covered is definitely very useful for all pediatricians, the practicing pediatricians all over the country as such. So this idea was thought about, and it was the concept was brought forward, and definitely we thought it was a good idea, and we started to roll it out. So this program, I believe, will be very useful for all the pediatricians because we start from the basics, and also I think so because March 10th was our World Kidney Day, and the topic is also regarding kidney. And I think so we just missed out on the Down syndrome. So maybe we'll come up with something in the next topic or set. But I leave it to the scientific team to take care of that part. I'm not getting involved. So anyhow, everybody gathered here, I believe it will be a really scientific feast for you all. And every month we plan to have 2 meetings, like another patient said, and hope the meeting goes well and all academics to everybody. And wishing the program all the best. Jai AP, Jai.
Thank you, sir. We are blessed by the presence of Dr. G.V. Basavaraja, respected National President of IAP 2024. May I invite Basavaraja sir to inaugurate the program.
Thank you so much, Soumya. So, respected our President of IAP Kerala, my close friend, Shimmy Paul, and Dynamic Secretary of the Kerala State Branch, Dr. Krishna Mohan, and always enthusiastic who have been working behind the scene for IAP over a year. And that is none other than our Dr. Jose, who was a very close friend of all IAPN. He works behind the scene. Really, it is a great work, Dr. Jose. And of course, our dynamic secretary of our national IAP, Dr. Yogesh Parikh, Dr. Balachandran, our executive board member, and Ranjit and all others. This is a program which is a very, very innovative program which is started under the action plan of an Indian Academy of Pediatrics of IAP Kerala branch with the scientific coordinator, Dr. Anand Keshavan, who has a rich experience coordinating and doing a great work of academics over the years. Anand Keshavan's blood is filled with the IAP. I'm sure the first program which is going to be witnessed by none other than our very young and energetic South Zone Vice President, Professor Singaru Velu sir. Singaru Velu sir, today also he was conducted one of the excellent academic program, physical program at Trivandrum. I think sir is there in Kerala only. So it creating an enthusiasm among all the members of IAP. Thank you, Dr. Singaravelu, sir. This program is also going to be watched by all the IAPN across the India. To testimony to that, already the number of people who has been attended, that itself shows how popular this program, that people are waiting to listen to the one of the stalwart in the field of nephrology. She is then very instrumental in starting a pediatric nephrology across the India, first MCI recognized course. So, of course, that is none other than Dr. Arpana Iyengar. So, was very, very instrumental in spreading the subspecialty. She is going to be the faculty here. That's a great news. So, I'm sure this is a series is going to be the people of India will be waiting for the IAP Kerala to roll out this program. With these few words, once again, wish you all the best. Thank you, Shimi and Krishna Mohan, Bala, Jose, Anand Keshavan for planning an excellent program. Wish you all the best. I declare this series is open for all the IAPNs.
Thank you, sir. Thank you very much.
Thank you, sir, for your kind words. Now, may I invite Honorary Secretary General of IAP 2024-25, Dr. Yogesh Parikh, sir, for the keynote address.
Thank you, Dr. Soumya. Thank you very much for the inviting. And this is the IAP Kerala program, Presidential Action Plan Program, PPP, Pragmatic Paediatrics from pioneers. So this is the best program, I think, in the leadership of Dr. Simi Flose, my dear friend and EB colleague, and Dr. Krishna Mohan, our dynamic secretary of the Kerala state branch, then the scientific convener, Dr. Anand Keshavanji, Dr. Naranji, and Dr. Ramesh Kumar, Dr. Jose, and Dr. Balachandran, Dr. Ranjit, and all the teams are working hard for this successful of this program. And today the topic is the nephrotic syndrome. And I'm seeing the stalwarts of the country, Dr. Sumantra Rao, Dr. Phagun Shah from my own place, and Dr. Arpana Madam from the Bangalore. So this is the this will be the best program. You see, I'm seeing the more than near to 100 people are joined on this platform, digital platform. So this is the success of this program. It is the seeing the whole the stalwart like Singaru sir is there, even traveling, even though he's there. Dr. Anjali Oti Madam, Dr. Anand Bhatt, so many stalwarts are seeing on this digital platform. So I think this will the Kerala state program will be the best program, academic program in the and under the leadership of Dr. Anand Keshavan and Dr. Simi Flose, Dr. Jose will be the best. And I wish the best wishes for the great success of this program. We have to join another meeting, so please bear us. Me and President sir will be joining another important meeting of the IAP. Thank you very much. Thank you for the invitation and the opportunity.
Thank you, sir. Thank you. Thank you, sir. Thank you, sir.
Thank you, sir, for your warm words and support. Now, may I invite Dr. Ramesh Kumar R., National President IAP 2022 for the felicitations.
Yeah, our dear friend Dr.
President,
Ramesh Kumar.
IAP Kerala, Dr. Simi Paulos,
President-elect Dr.
Thank you,
Riyaz.
Ramesh sir. Sorry, we did not see. Thank you, Ramesh sir.
Rameshji.
I thought you were
We got
outside.
missed.
We both missed it.
I understand. Please proceed. I can understand your
We
Yeah,
joined through the
and
mobile. That's why we did not
very
see.
much
Yeah.
happy to- Please proceed, Basav, Dr. Yogesh. I'm so thankful that you are joined for the meeting on behalf of IAP
Yeah,
Kerala. We are really proud and happy about it. Okay, President IAP Kerala, Dr. Shimi Paulos, President-elect Dr. Riya Sai, our chief guest and my beloved friend Dr. Basavaraj, the National President of Indian Academy of Pediatrics, National Secretary, the most dynamic Dr. Yogesh Padik, and of course, the State Secretary, Dr. Krishna Mohan, Dr. Ranjit Treasurer, Gopi Mohan, Joint Secretary, and the key persons behind this our program, the PPP, Dr. M. Narayan, the convener, Dr. Jose, the most dynamic, the state coordinator, and of course, the scientific convener, the man behind the science behind IAP Kerala, Dr. Arda Kashapan, Dr. Balachandran, the executive member, as well as the state coordinator. And I can see the lot of members right here, Dr. Jitendra Gawane, as well as the state great teacher, Pranam sir, and as well as Dr. Hari and many other seniors. And of course, the faculty here for the day, Dr. Sumant, as well as Dr. Aparna, Dr. Aparna and Dr. Fagun, and all my dear friends on the platform. So heartening to see the academics under IAP Kerala going. It's happening every day and every week, time and again. But again, coming up in a new format, the PPP. PPP is something like a very catchy synonym, but then Pragmatic Paediatrics from pioneers. And I'm pretty sure that Dr. Narayan and Dr. Jose, under the guidance of Dr. Ananda Kesavan for the scientifics and Dr. Balachandran, will be really taking it forward in a very, very healthy way, and something which we have enough and more of academics coming up from the Zoom the virtual platforms. But again, every innings is every time it's a learning experience. And for me, if you say UTA basics and beyond, if I want to listen to that, time and again, I just have something get some bit of information from a new session. So it's always for a pediatrician, it's good to see be on the platform at least for 10 minutes or 15 minutes and take home 1 or 2 messages from every session he attends. And that's the virtue of the virtual platforms. It's a great time for IAP, Central IAP, where it's going with a lot of academics from the institutions and a lot of academics from the guidelines. And from IAP Kerala again, lot much on different the different platforms. Dr. Shimi and his team, Krishna Mohan. So it's a great learning. It could be really has to be a really great learning experience for all of us. And I really am congratulate IAP Kerala for taking this initiative and especially Dr. Ananda Kaswan and Dr. Jose Balachandran, under the stewardship of Dr. Shimi, Riyaz, and Krishna Mohan, and Ranjit, and all others for taking this forward. I wish this could be a late training experience for all of us, and truly we'd be looking forward to that every alternate Friday on the Zoom platform for some extra learning experience for IAP. Congratulations and best wishes, and to all my dear IAP, all my friends on the platform. And I am sure you will in for something new from all these sessions. Best wishes. Thanks, my dears. Thank you.
Thank you, Ramesh.
Thank you, Ramesh Kumar sir. Now may I invite Dr. Shingara Velu sir, Vice President of South Zone Vice President of Central IAP.
Good evening, ma'am. I'm just getting down from the train at Tirunelveli. At the outset, I really congratulate the team Kerala for initiating this Triple P program. And this day, my best wishes, the most respected National IAP President, Dr. Basavaraj sir, and HSG, and my good friend IPP, Ramesh Kumar sir, the team of IAP administrators of Kerala, Dr. Simi, Dr. Krishna Mohan, Dr. Ranjit, Dr. Yusuf, Dr. Arun Keshavan, my good friend Dr. Bala, and all young energetic team. And today's scientific team is extremely useful for both not only for practitioners and also for consultants. And Aparna Iyengar is known to me for quite long time. She is a great academician. I am sure this program will be very useful. Already more than 100 people have joined and all are waiting for the great academic piece. I don't want to take much of time. I am much thankful to all members of Kerala, my good friend to Ananda Keshwan for initiating me and welcoming me in this August forum. And I'm sure that every 2 weeks on this day, Friday, you all will join to learn a lot from the stalwarts, which you are all going to arrange in future days. My best wishes for this academic piece for the coming year. And as a South Zone Vice President, it is a great honor and privilege to be associated with you all. Wish you all the best. Thank you for giving me this opportunity. Thank you to all. Thank you.
Thank you, sir, for your encouraging words. Now, may I invite Dr. Krishna Mohan, Secretary, IAP Kerala 2023-24, for the felicitations.
Thank you, Shweta. So, respected Chairperson, President IAP Kerala, Dr. Shimi Paulus, most respected National President Basavaraj sir, Yogesh Parikh sir, my dear teacher and the national convener of this program, Dr. Ananda Kesavan, Ramesh sir, and all respected persons in this group. So, at the outset, the main person I should thank for bringing out this program is none other than Dr. T.M. Ananda Kesavan, my own teacher. He is the scientific convener of the program. When we were thinking about this program, he was the one who suggested that I will take care of this, because a program of this, we need a lot of faculties from the national arena to conduct this program. So with his contacts, because he has been the national EB member for around 6 times, and he was a national vice president. So sir was the person who gave us courage to conduct this program. And I think majority of the part of this program was planned and executed by Ananda Kesavan sir. So thank you so much, Ananda Kesavan sir. And to help him with this program, Dr. Jose O, as well as the state convener of this program, Dr. Narayan M, was also there. So I am sure this program will be a big success because in this first episode itself, I am seeing around more than 100 participants, and the YouTube also is full now. So thank you so much. Best wishes for this program. Thank you.
Thank you, sir. Now, may I invite Dr. Jose O, Dynamic State Coordinator of Pragmatic Paediatrics from Pioneers Program, to deliver the vote of thanks.
Thank you, Shweta. And respected our National President, Dr. Baswaraji, our State President, Dr. Shimi, our National Secretary General, Dr. Yogesh Parikh, Vice President, Dr. Singarveluji, and our immediate National Vice President, Dr. Ramesh Kumar, and our national convener of this program, Dr. Ananda Kesavan, Dr. Bala, and Dr. Krishna Mohan, Dr. Ranjit, and all the seniors who are joined here. This is a first program we are planning to conduct a national level program action plan, and the academic activities of IAP Kerala is concerned. Triple P program. I think this is the vision of and our President Dr. Shimi Paulos given all the support for organize the program, because already we are conducting a lot of academic is there. Still we are planning to have a regular every alternate Friday we have a academic feast for with stalwarts in the young states in the field of field. We are planning to have conduct the program. I think today the program under leadership of Dr. Arpana Madam and Dr. Fagun Shah and Sumendra Kumar Raut. I think this program is very enlightening for all of you regarding the academics of nephrology is concerned. And as I come to my duty, and today the program inaugural function, we are conducting this program inaugural function. Next week onwards, we are straight away go for academic event program. And today we are conducted the inaugural function, and as a coordinator the program. Thank to our beloved Chief Guest Dr. Baswaraji and for his busy schedule to come over here and inaugurate the program. And on the behalf of IAP Kerala and personally, thank you, Dr. Baswaraji. And again, Yogesh Parikh is also having multiple action program today night, and in the busy schedule, he also accepted our invitation and participate as a keynote address. Again, our national Vice President Dr. Singavi sir is traveling for so many academics and coordinating action plan of Central IAP. And on the behalf of IAP Kerala, thank you, Singavi sir, for attending and blessing our conference. Again, our Ramesh Kumar, our member, is a national president of IAP Central IAP 2022. Given that taken the opportunity to come over here and facilitate the program and with the coordinating this program. And again, the president of IAP Kerala, Dr. Shimi, has taken all the initiative to coordinate and support the program. On the behalf of all of you, I thank you, Dr. Shimi, for arranging wonderful academy for all of us. And again, the Krishna Mohan, Dr. Antagashan, the national convener of this convener of the program, he's a man behind the coordinating the program because he's a man with the academics always. He is whenever he goes along with IAP activities, whenever he's come to any activity, he want to academics, pure academic in all the level. So he is a man behind coordinating the program. I think this in coming weeks and also this program under leadership of Antagashan will enlighten our pediatrician regarding different aspect of our common practice of pediatrics is concerned. Again, I thank all the seniors who joined here and from inside Kerala and outside Kerala. A lot of members are joined already. Our Zoom is more than 100. Again, our YouTube was full with more than 200 members are joined to the YouTube also. I think this is a great moment for IAP Kerala. Again, I thank Dr. Arpana Madam and Dr. Faculty, Dr. Fagun Shah and Suman Kumar also accept our invitation and come out with the program in an excellent manner. I wish you all the best. Good evening, good learning, and all wish you all the best. Jai Hind, Jai IAP.
Thank you, sir. With this, we come to the end of the inaugural session. Now, moving on to the scientific session, may I invite Dr. Anandakeshavan, sir, to introduce the speakers and the moderator and proceed with the session.
Okay. Very good evening once again. We acknowledge the presence of Jitendra Yahani and also Dr. Srinivasa, Senior Pediatrician from DIPMA, and all other members. We discussed about the program during World Kidney Day. That is why the topic came to be nephrology topic, because World Kidney Day means over just only 1 week before. That is why we specifically about, and also we got a very good young dynamic nephrology. So we had great pleasure to welcome our own Arpana Iyengar from Bangalore as a moderator for today's program. She is a professor, Department of Pediatric Nephrology, prestigious St. John's Medical College, Bangalore. She got so many international credential on credit, extraordinary. I never say so much international reputation and all award like that. She is chaired International Society of Nephrology and a mentorship program. And also she is convener of ISN Scientific Writing Course. She is member Pediatric Acute Disease Quality Initiative Collaborative 2022. And she is past year ISN Clinical Research Program, steering committee member. She is subject editor, ISN Academy. She is associate editor, Indian Journal of Nephrology. She is author, Awareness Textbook of Pediatric Nephrology and a Brenner's Textbook of Nephrology. So we are very lucky to have Madam here. Thank you, Madam, for accepting our invitation and moderating this session. Now I hand over to you, Madam, to present the moderated session, introduce the subject and also speakers. Hope that you can introduce speakers and also both subject also.
Yes,
Over
sir.
to you, Madam.
Thank you so much, sir. Good evening to leaders of National IAP Kerala. Particularly, hearty congratulations to IAP Kerala for launching this academic series. Today, we are going to discuss two common and important topics in pediatric nephrology that I'm sure is seen commonly by pediatricians because they are the first contact physicians for children with nephrotic syndrome and UTI. These two topics have got a new evidence over the last few years, and therefore we have new guidelines that have been published in Indian pediatrics, both for UTI and nephrotic syndrome. And to give us all an updated overview of these two topics, we have two eminent speakers. Dr. Sumantra Kumar Roth, he's a pediatric nephrologist. an assistant professor in Department of Pediatrics, North Bengal Medical College, Darjeeling. He is an active member of the Indian Society of Pediatric Nephrology and is the ISPN East Zone representative. He's also been very active in conducting training programs in pediatric nephrology for the state of West Bengal. I welcome Dr. Roth and request him to share his slides for the first talk on nephrotic syndrome for practicing pediatricians.
Good evening, everyone. Hope I am audible. Warm greetings from West Bengal, and thanks to Aparna ma'am for the nice introductions. At the outset, I would like to thank the IIP Kerala team for inviting me in this Triple P program in the inauguration one, and also the senior members of our central IIP who has been the main mentorship, doing the main mentorship for this program. So I'd like to share my screen, but probably the host has to make me able to share.
Ranjit, please make a
I'm till now disabled, so please make me able, please. So till the
Ranjit,
Make both speakers co-host.
Dr. Suman, just try now.
Yeah, same thing. Actually, I have two devices. So no, not that devices. There is a Suman Kumar Raut. The device name is Suman Kumar Raut.
You can join two devices. That's why it's a
Yeah,
connection.
right. Suman Kumar Raut. Can it be possible?
Yeah, I made both.
Yeah, it's fine. So I'm trying to say it. Hope I'm audible, na?
Audible, sir. Audible, sir.
You are audible.
Okay.
And for the audience, if you have any questions, you can put your questions in the chat box.
So is my screen visible and in a full screen mode?
Yeah. Everything is okay, sir.
Okay.
You can proceed.
So once more, thanks to our Kerala IP team for making me the opening batsman of these sessions, and I think I can make a good justice for this common topic, that is nephrotic syndrome, in our practice for practicing practitioner for our fellow pediatricians of Kerala and all over the India who are listening today. So I will be running through some the main key points which we face in our day-to-day office practice, including the recent changes in our latest guideline of Indian Society of Pediatric Nephrology that was published in Indian Pediatrics in 2021 that Aparna ma'am just told. So these are the most familiar faces that we see in our day-to-day cases. They might be looking similar. Their disease might be a little bit different. Their outcome might be a little different. So some are edematous, puffy, some are cusinoid, and some are in combinations. So mostly whenever, as this is a nephrotic syndrome topic, so mostly whenever these faces come to our mind, firstly we think of nephrotic syndrome, but obviously there are some other differentials also in our mind going on. So this is a case, mostly this is a case-based discussion to make it more interactive. So this is not a pure didactic one. So if people want to interact, they can put in the chat box or raise hand. So Vishnu Chatterjee is a 9-year-old boy. He has a puffiness for last 4 days in January 2023. There was no such prior history. So this is Vishnu. So what regarding if such a child drops in our day-to-day OPD, in a busy OPD, what are the key positive points we need to check him out? What are the key negative points we need to check him out? So at least we ask for how many days this another case going on. Is there any associated low urine output or not? Is there such previous history of puffiness earlier? Any steroid or any other drugs taken for these conditions? And most important, which we often forget, because is there any history of contact with tuberculosis? Because mostly if it is a nephrotic syndrome, we are going to treat with a long-term immunosuppressants of steroid. And also, if such similar history in family exists for nephrotic syndrome or other kind of nephritis, because rarely the steroid nephrotic syndromes or some familial nephrotic syndrome may do exist in our day-to-day career. Regarding on the same tune, we need to ask proactively regarding some complications also. Many a time parents might miss to tell that their child has some tummy pain also, or there is some redness in the lower abdomen, which we often going to miss in our clinical exam. That has to be proactively asked for during this contact. And many a time, if it is at onset of nephrotic or maybe a relapse of nephrotic, many a times there are some triggers, and mostly in Indian scenarios or in some tropical scenarios, viral URI or the diarrhea can be some triggers for these nephrotics. And that can have some implication in our further treatment also. Parallelly, we have some negative differentials in our mind also. So we need to take some negative history to rule out other causes of anasarca, just like other nephrological causes. Acute glomerulonephritis might be AKI or CKD, might be an UTI, might be some non-renal causes like liver disease, like heart disease, and so on and so forth. So is there any history of hematuria, any history of rashes, generalized rashes, any arthritis, any lower oral ulcers, any history of lower urinary tract symptoms, they can divert our diagnosis to those other differentials. Regarding examinations, I know in a busy OPD it's very difficult to do a complete examinations, but for nephrotic cases, it's very essential to at least measure the blood pressure at the onset once, because the blood pressure can be really high due to primarily the nephrotic syndromes, or might be due to the side effects of the drugs like prednisones, or maybe of cyclosporine. During examinations, we usually see the edema, but rarely we sometimes miss to examine the genitals. That because if there is a genital edema, that signifies that this is a severe edema, and that kid might require admission. Others, there are some features of some abdominal wall cellulitis, redness in the skin. And most of the cellulitis by default are in the lower abdomen or in the inner aspect of the thigh. And in a busy OPD, particularly in a government OPD, where a little bit privacy issue of examining bigger kids like 10 years or 12-year kids, it's very difficult to examine such child. You need to remember we have to examine the area thoroughly, otherwise we can miss some significant and morbid complications. So this nephrotic syndrome has a good prevalence of around 8 to 15 per 100,000 age-related population, and the incidence is around 2 to 5 per 100,000 population. And mostly for Southeast Asian population, the nephrotics has more severe manifestations in our population mostly. So though this is the population, it comes under a rare disease, but we need to remember that this type of puffiness are also common in case of angioedema, and which is at least 5 to 10 times more common than nephrotic. So don't get astonished if some prescription from the periphery comes with a child with puffiness, given some atarax, the child didn't respond and came to us with the frank nephrotic features, because many of those child are actually angioedema and they do respond with atarax or some antihistaminics. So on the same tone, regarding the definition of nephrotic syndrome, as we all know, it's an age-old teaching that it consisted of 4 prongs of diagnosis. Number 1 is proteinuria. That is a massive one. Urine protein 3+ or 4+ in a dipstick, or maybe a spot sample or time sample showing huge nephrotic range proteinuria. And just remember, there is a thing called protein creatinine ratio. The spot sample PCR, that should be more than 2. And don't confuse with an ACR, because most of the lab, when we write PCR, they wrongly does an ACR, that is albumin creatinine ratio. ACR is done in background of CKD patient and not in case of background of nephrotic or nephritic patient. For nephrotic or nephritic, we need an PCR and not ACR, because ACR cutoff, there is no such ACR cutoff for diagnosing nephrotic per se. The second option was edema. So at the onset, at least most of the child will present with a severe edema also. As a classical book teaching of undergraduates also, the edema starts with face, but many a time it can vary also. The third important point was hypoalbuminemia. Initially, when we are the students or doing our post-graduation, the cutoff of albumin level was 2.5. But currently, the cutoff for since last 2016, 2017, the cutoff has been changed to less than 3 gram per DL. Might be due to the testing procedures also. And the fourth one, and one of the important prongs, was hypercholesteremia, that is more than 200 of serum cholesterol. But our recent Indian guidelines has dropped this condition of hypercholesteremia as a part of diagnosis. But still, we need to send these blood levels just to confirm our diagnosis. On the same note, just like urea and creatinine, the renal function test, which is not a part of definition of nephrotic, but we need to send it for 100% cases just to document a normal urea creatinine for our nephrotic cases. So cholesterol, high cholesterol has been dropped from the definition, but still we are doing as a test, and urea creatinine we are doing as a test. So coming to this is the recent changes, what Arpana ma'am was also talking about the last ISPN guidelines for nephrotic syndrome, both for steroid sensitive as well as steroid resistance. Regarding investigations, we usually do very selective investigations for a case of nephrotic. They don't need high-fi investigations. So minimally, the serum urea creatinine, the albumin, the cholesterol, and if the child is having long-standing disease, the serum electrolytes, look for hyponatremia, hypokalemia, etc. And obviously, a urine test, that can be a urine routine test to test for the proteinuria, and also absence of hematuria, absence of RBC in the urine. Many times, if there is a doubt in the diagnosis, we need to send some urine proteinuria quantification for a time sample or maybe a spot sample that we have already discussed, the PCR ratio, protein creatinine ratio. For selected cases, we need to send other tests, just like a MANTU test. It can vary from center to center. People are sending or not. Many a time for high burden, a country with a high burden of hepatitis B or C can send the hepatitis B or C at onset. But for most of the centers, we need to know that what is not required for a routine test is a urine culture, which is the most commonly wrongly done in our common practice. As because nephrotics are immunosuppressed, many people think that UTIs are probably more common. But if the child has no symptoms of UTI, better not to send a culture. And if anybody has wrongly sent a culture, better to ignore that one. So urine culture is not a routine test for nephrotic unless symptomatic. And so also serum complement 3 is not a routine test for first episode classical idiopathic nephrotic syndrome. And regarding treatment for the first episode, as you all know, the treatment is 6 weeks of daily steroid, documented remission, and then change to 6 weeks of alternate steroid. The daily steroid is either 2 milligram per kg per day in 1 or 2 divided dose, but not in 3 or 4 divided dose. Earlier, we are treating with suppose 4 divided dose that hampers the compliance. And now some studies have also shown that even once a day dose is also better regarding the HPA axis regulation. But at least 1 or 2 divided dose for the daily therapy seems to be fine. And many a times, whenever we have facility to measure the height also for the child, the BSA, it's always better, particularly for a smaller kids, to assess it in case of body surface area. That is 60 milligram per meter square per day in 2 divided doses. But if you don't no time for this one for BSA or for the height, you can jolly well go for the body weight formula also. And for alternative regimen, it is 1.5 milligram per kg on a single morning post-meal dose for 6 weeks. So in short, this is called P6 plus 6. And there is a sudden stoppage, no tapering at all. And PREGNOS 2020 trial has already shown that prolongation of this therapy has no added advantage in form of efficacy. And always there is a P6 plus 6 as a red color plus. That means in between changing between daily to alternate, we need to document a remission properly, either through a dipstick for 3 to 4 continuous days or maybe a spot PCR ratio. And regarding subsequent episode, so regarding our routine treatment, if we are giving for this definite duration of 6 plus 6 weeks, we don't require any regular calcium unless there are features of hypocalcemia. We don't require a regular antacid unless there is a steroid gastritis, which is actually rare in case of pediatric patients. Regarding monitoring, this is coming to the more important one, because nephrotic being a prolonged disease, a relapsing disease, it will may continue up to 14, 15 years. So whenever your child is in between better, we need to also monitor the child at home daily basis through their urine morning dipstick. So these are the dipstick. To avoid confusion, better to cut the glucose part, because many times it happens that moms are taking the glucose wrongly and there is a chaos of treatment. And we need to tell them that they have to maintain a diary regularly, where they have to mention only simple thing, date, urine protein, and only the steroid doses, and not weight, not water intake, not this one. This one is not required for a daily home therapy, because if you made the daily home diary complicated, the mom will do for 1 month or 2 months maximum. After that, they will drop doing it. So it's better to make it simple so that mom can do it for a prolonged time. And whenever next time onwards, the mom should comes to us with the relapse through this diary only and not with the edema. The diary is only made because we can catch the edema, detect the relapse earlier before a edema starts. So regarding this home protein diary, if the child is admitted for edema control in a hospital, that time we might need the water intake, the urine output, the weight gain, this one, but it's not for a home therapy. So we usually, our senior pediatrician obviously sees lots of dozens of nephrotic per day in their OPD, I know it. But what are the most common variety of nephrotic that we regularly see? Is it an infrequent relapse, IFR? Is it a frequent relapse, FR? Or is it a steroid-dependent nephrotic? What we, in common sense, what we feel. So mostly, many times, sometimes it looks like that mostly we are facing infrequent relapser or first episode in our office practice. But actually, it's not. The most common variety is the FRNS or the STNS variety. So only single episode in lifetime is only 10 to 20%. IFRNS or infrequent relapser are 15 to 20% only. IFR means, I will come to the definition a little bit later. And the major bulk is the frequent relapser or the steroid dependent one. And why these two both are in a single box? Because if the mom is not doing a good diary, many times it's difficult to difference between this FRNS and this STNS category. And rarely 10 to 15% can be an steroid resistant nephrotic syndrome. So by default, this is the second case. Suppose here we comes to the normal physiology. This is Sudeep, a 7-year boy. He has an onset of nephrotic in January 23. He has a first relapse on September 23 and a second relapse on December 20. So as per our older policy, any child who is having 2 relapses in first 6 months or even 2 relapses in any 6 months was diagnosed as FRNS and treated with long-term agent. So as we know that for daily therapy, we are treating with P6 plus 6, and on a same tune for a alternate therapy, I think there is some which is, excuse me, please. Just pardon me. I think Can I please stop? That's fine. That's fine. It's okay. So for first episode therapy, the treatment is P6+6. Similarly, for first relapse therapy or the subsequent relapse therapy, the therapy is just half duration of the first episode 1. It is P2+4. 2 weeks of daily therapy followed by 4 weeks of alternate therapy. And before switching from daily to alternate, just document a remission. And after that, no tapering. There is a sudden stop for first relapses. So for subsequent relapses, if they are infrequent relapses, that means 3 episodes or less in a year, then they are treated with this small therapy every time, P2+4, and low long-term agent. But if unfortunately the child becomes an FRNS or an STNS, that is frequent relapser, that means 4 episodes or more in a year or 2 episodes in first 6 months, then the child needs a prolonged agent, any second agent. So the recent changes in our Indian guideline is that this extra category, if there are 3 relapses in any 6 months, then the child will be categorized as FRNS. So this child Sudeep has within this 6 months has 2 relapses, but this 6 months is not the initial 6 months. This is in between. So this is not an FRNS. This boy is ideally an IFR, and we need to treat with P2+4, 2 weeks of daily and 4 weeks of alternate. Suppose this Sudeep again on subsequent courses develop 2 more episodes, and now he becomes an FRNS. So what's now? Now we have checked his eyes. There was cataract, and the dad is a daily wager. So what the second agents we will choose for this Sudeep? Now we will not treat with only P2+4 and stop, because FRNS and STNS have been treated with a long-term agent, and the options are either you treat with a long-term alternative steroid for at least a year on a low dose, or any steroid sparing agent like levamisole, cyclophosphamide, mycophenolate, tacrolimus, or rituximab. And these are in series, in 1-by-1 series, not in a haphazard scenarios. So this is Sudeep, hugely cushingoid, obviously edematous. We need to treat her this relapse and then to start any second agent. So these second agents are stage-wise done, because the more upwards you go, the agents are more potent, they are more toxic, and many a times they are costly also. So better not to jump one agent unless it is indicated strongly. For each agent, if we give 2 years for each agent, the usually nephrotic syndrome starts at age of 3 or 4 years, and by the age of 14-15 years, there is a natural tendency for going into persistent remission. So if we use each agent for 2 years, for 5 agents, 10 years of career has been spent. If we jump a agent and start for a CNI directly to an FRNS, then we may land up in no therapy in our hand. For the second line therapy, for long-term alternative steroid is been used if there is no toxicity, no cushingoid, no cataract, nothing. But if the child is having some cushingoid features, we will better go for levamisole, the mildest among the steroid sparing agent. If the child is having cataract, our options are either mycophenolate mofetil or a cyclophosphamide, oral drug. Cyclophosphamide is better used for more than 8 years of kids. There is some potential side effects for gonadotoxicity, but for 8 to 11 years, it's a good agent, and obviously cheaper version also. For MMF, they works wonder with the younger kids, but little bit costly. And regarding our Indian scenario, we need to think of this also, because nephrotic syndrome is a prolonged disease. We need to concern about the compliance, the cost, etc. before prescribing any drug. And if the child is having severe toxicity like diabetes or anything else, we have to opt for either tacrolimus or either cyclosporine or maybe a rituximab. So this is the third case. This is Vishnu. This is a STNS girl, steroid dependent. She is already on MMF because small girl STNS. So we choose for MMF for this child. So this child has been admitted in our PICU with severe edema and severe pain abdomen for 1 day. The blood pressure is normal. The extremities is cold. This girl is actually admitted on a periphery hospital and later on was shifted to our hospital. So on periphery hospital, the pediatrician attended this kid. And what is our knee-jerk reflex after seeing the child? The severe pain abdomen. So anybody will, by knee-jerk reflex, will think of peritonitis or the SBP, spontaneous bacterial peritonitis, and we'll push some antibiotics like ceftriaxone. And regarding edema, many times we'll end up of giving a single dose of Lasix to decrease the edema. So no wonder all the blood tests and biochemistries were sent, but in periphery hospital, the reports comes after a day. So the treatment was started without any delay. But for the wonder and for the dismay, after giving the dose of Lasix and the ceftriaxone, the pain abdomen didn't become better. It worsened. Pantoprazole, Drotin, etc. was given. But the dismay was there was an episode of seizure, general tonic seizure. The child was given a single dose of Eptoin and was referred to our hospital. And when she came to our hospital, the reports are already in our hand. And also by looking after the history, there was no particular history of fever. So any child, any nephrotic child with pain abdomen, we always should be remembering of three differentials. The first one should be a hypovolemic pain abdomen, the peritoneal ischemia. The second, the interstitial ischemia. The second one can be a peritonitis or the SBP, spontaneous bacterial peritonitis. The third or rare maybe some steroid gastritis, maybe some steroid-induced pancreatitis, etc., etc. So always before thinking of SBP, keep your eye open regarding hypovolemia because the treatments are entirely different. So now the blood tests are in our hand. She has a very high urea. The creatinine is normal or even subnormal. The albumin is too low that can cause a prothrombotic event because nephrotic is per se a prothrombotic condition. The hemoglobin is very high, again denoting a hemoconcentration or a hypovolemia. And there is metabolic alkalosis or the contractile alkalosis. Forget about the total leukocyte counts because the total leukocyte counts or the neutrophil counts for a child who is on high dose of steroid for steroid dependence might increase the TLC by steroid itself and not necessarily infection. Rather, we can see for the CRPs or maybe a history of fever that can denote a case of SBP more than a hypovolemia. So now we can think after this investigation, mostly the child is suffering from hypovolemic pain abdomen or not the peritonitis. Still, if in doubt, we need to do a peritoneal tap and rule out the SBP. So we did a tap, and for nephrotic syndrome case of peritonitis, the cell count should be more than 100 and more than 50% neutrophil to prove a ascites. And here the cell count is less. So this is not a peritonitis anymore. So the diagnosis is hypovolemia. We also had, and the treatment, we need to restore the volume by some bolus fluids. And after that, once the volume is restored, we need to treat with albumin, followed by a Lasix and not a first dose of Lasix at the onset. So, and regarding the general tonic-clonic seizure, mostly the seizure episode is due to the prothrombotic condition. There may be some cortical sinus venous thrombosis, CSVT, and we need to do either a CCT in an urgency can show a empty triangles, delta signs, or maybe a better diagnosis on MRV, MR venography can show a void in the venographs. So this child needs to be treated with warfarin or low molecular heparin or in combination for their CSVT part also. So remember, this type of complications may happen, and if you forget or miss the cause of hypovolemia, gives a dose of Lasix, they will create a more hypovolemia and those subsequent complications. So remember these things. So for regarding edema control, the first line for our ISPN treatment guideline is to rule out the hypovolemia. If there is any chance of hypovolemia, just start with a albumin or any fluid bolus and then gives diuretics once the hypovolemia is restored. And if there is no hypovolemia, we can start with, if the edema is moderate to severe, then only the edema requires treatment. Mild edema does not require any treatment. Steroid will manage the edema itself. So for moderate to severe edema, we can start with oral Lasix for 1 day or 2 days, but not for days together like in a cardio patient. And if the oral Lasix is not working or the edema is severe to start with, better to have one intravenous Lasix doses, either intermittent bolus doses or maybe a continuous infusion. And at any time point, if there is a severe hypovolemia, always start with albumin infusion and then add Lasix. So this is the edema control step for a nephrotic. Regarding counseling to the vaccination, though this child don't have an SBP, but he has a full chance to develop SBP or peritonitis in due course. And mostly it is done by gram-positive bacteria, the pneumococcal. So vaccination is an important part of nephrotic, and many a times they are on multiple steroid doses since 2 years or 3 years of age. So after 1.5 years of age, they miss their vaccinations quite often. So the most common vaccinations to be ensured is pneumococcal, influenza, and hepatitis B regarding kill vaccines, and varicella regarding live vaccines. But we need to remember the contraindication of giving the vaccines. So whenever on any second agent, we need to stop. We cannot give any live vaccines to the child, and not only to the child, the siblings also cannot get any enteral live vaccines like oral polio. But the sibling has to be given the parenteral live vaccines like varicella for the healthy siblings. And once the child is off prednisolone for or any immunosuppressant for more than 4 weeks, we can give these live vaccines. For rituximab and cyclophosphamide, this is 3 to 6 months of gap is required. For kill vaccines, if a child is on prolonged steroid, once the dose is a little bit lesser, less than 0.5, we can give this type of kill vaccines. The efficacy might be a little bit less. So regarding this pulse polio dose, many times we forgot to mention our patient that if a child is on every second agent, don't give pulse polio to the child, to our patient, and also don't give to this pulse polio to your healthy siblings and the same home. So these are some spotters, the common side effects we encounter. This is a 11-year-old girl, a black girl with more black interpharyngeal joints. So this is a hyperpigmented knuckles. Most common complication for cyclophosphamide and innocuous side effects, so no need to stop the drug. This is Disha, a 13-year-old girl, steroid dependent again, suddenly developed this red urine on some second agent after using some second agent. So this is an hemorrhagic cystitis. So most likely this is cyclophosphamide induced. So whenever the child on cyclophosphamide developed a red urine, we always need to think of hemorrhagic cystitis. We can think of any UTI because they are immunosuppressant. That can be adenoviral UTI also. Cyclophosphamide can cause cytopenia. So low platelet can cause this hemorrhage. And many a time nephrotic are prothrombotic. So they can develop renal vein thrombosis and hematuria. So this has to be think in mind. And the final one, this is an 3-year-old boy on some second agent with this red type of rashes, some patches in her ear. So this is a case of vasculitis rash, vasculitis patch, and this is due to levamisole. So these side effects actually is a little bit recently known for last 3-4 years. Whenever this levamisole we are using for a long time, they can cause ANCA vasculitis. So as per our guideline, if you are using this levamisole for a long time, better to test for the ANCA. Many guidelines also says to start with the ANCA test and then start levamisole. So regarding this, Vishnu, the first child, Vishnu, once they have a relapse, we did a urine test. There was 4+ proteinuria. We are planning to start our steroid. But unfortunately, there was some pus cells, 8 to 10, though the child don't have any symptoms. And we sent a culture also. The culture was E. coli, 10⁵, and we were sensitive to Taximo. So are we going to start Taximo, or the child is immunosuppressed, so we are going to start some higher agents, maybe a meropenem or something else? So actually, the bottom line is, if a nephrotic has no symptoms of UTI, don't regard this as UTI. This type of pyuria or WBCs or even RBCs can come due to a part of nephritis itself. So this is not an UTI, not to be treated, better not to send a culture even. So on the same tone, we just once recapitulating the definition of UTI, there has to be symptoms of UTI, then a significant culture colony count will have the definition done. So when these simple steroid dependent cases need to be referred to a pediatric nephrologist only if the child in due course becomes steroid resistance, or the child is at the onset is frequent relapser or STNS. We have 4-5 basket of choices of drugs and we need to select a drug. Better to have a pediatric nephrologist in the loop to start with. If the child is an infant with nephrotic, if the child is have some genetic variety or a familial history of nephrotic, or maybe some syndromic part like some nail patella syndrome or any other symptoms, then better to have a pediatric nephrologist in loop. If there is some treatment related complication, just like this type of ANCA vasculitis or cyclophosphamide induced some hemorrhagic cystitis, better to keep your nephrologist colleague in your loop. And if there is some disease related complication like SBP or severe refractory edema, unable to treat by Lasix for days together, better to have a referral for pediatric nephrologist. So the take home message is, majority of nephrotic syndromes are steroid sensitive. They have a very good long-term outcome. After 14-15 years, more than 95% patients are going out of this disease. So we need to have some perseverance. We need to counsel the mother well. So don't do doctor shopping one after another. Just maintain a good diary at home and stick to a standard protocol. Urine dipstick diary has to be done daily, even if the child is not on steroid. Better to monitor the side effect on a regular fashion. The cataract and this glaucoma are oftenly missed because we are not sending the patient, and this mild cataract is not symptomatic. Complicated steroid dependent or FRNS cases need to have a pediatric nephrology opinion. And there is no, this is an important part, though we have not covered in this topic, the diet restriction. Many a times we, most of them tell, ye nahi khana hai, wo nahi khana hai, not to give this diet, not to give that diet. Our childs are food fuzzy. So no unnecessary diet restriction, and particularly no zero salt. Many a times we tell less salts and mom make it 0 just to protect their kidney. Many a times child lands up with hyponatremia. So less salt and some maybe increased protein during the protein diet regarding that one. And vaccination not to be missed because our kids by default due to steroid therapy miss many sessions of vaccinations. So it's whenever we get a scope of steroid-free duration, better to give all the UIP vaccines and the 3-4 optional vaccines, which are most important for our nephrotic kid. So by these things, I might stop our talk, and whenever our chairperson feels okay, I can make the answer of the query. So this is our World Kidney Day celebration, which Dr. Anand was just telling about in our North Bengal Medical College. And with this thing, I conclude my session. I am stopping my screen. Over to our chairperson, ma'am.
Thank you. Thank you, Dr. Roth. It's amazing that you covered A to Z of nephrotic syndrome in less than 30 minutes. And you've actually covered all the main points that the guidelines provide. So from screening to making a diagnosis to clinical course to complications, highlighting even the usual myths and caveats that pediatricians could face, up to counseling. So I think this is the entire spectrum of care for a child with nephrotic syndrome. We did have a couple of questions in the chat box, and there are two more. I would be happy if you could answer them. Dr. Keshavan has asked about the indication for genetic testing in children with nephrotic syndrome.
Actually, I voluntarily skipped that one because many a time it is not a regular fashion for our practicing pediatrician, but if asked, I can answer. For Indian guideline, it is a bit different. We usually do a genetic symptom upfront. If our child is steroid resistant nephrotic syndrome, we have done an biopsy and we have given an tacrolimus or cyclosporine for 6 months, and our child failed that therapy. So CNI resistance cases, number one. Number two, if the child is having an infantile onset nephrotic or maybe even 6 months, less than 6 months onset of nephrotic, many times we don't do biopsy upfront. Rather than we can do a genetic test, and the yield is much more if the child is younger in age, particularly for congenital nephrotic for less than 6 months old nephrotic like this. And if a child is a part of syndromic nephrotic syndrome, just like I told that for a nail patella syndrome, or maybe some other syndrome, some Gallagher-Mowat syndrome, this syndromic child, or maybe this same kid has a siblings, maybe 3-4 years older and having an SRNS course. In these cases, we need a genetic disease to be looked for. And another one extra was there regarding transplant that I'm not telling you now, that I'm skipping one.
I'm asking the context of 3 members from the same family affected. That is why I asked, sir.
Okay, okay, sir. But this is
And, my next question is that
for SSNS regarding for if the 3 members are steroid sensitive, probably we might not need genetics, sir. If somebody is steroid resistant, then might be. Okay, sir.
My next question, Madam, we are seeing so many cases of cataract because with the usual routine mass, we recommended dose everything. I don't know whether it is too frequent because we are getting 1 case per 2-3 months like that. So
Yes,
what to do? How to prevent it?
Rightly
we have
pointed.
published a study on the prevalence of cataract and glaucoma in children who are exposed to steroids with nephrotic syndrome in 2013, Indian Journal of Pediatrics. So 1 in 9 children had cataract and 1 in 4 children had glaucoma. And if you look at the risk factors, which of these children with nephrotic syndrome end up with cataracts, it was the older children. So though younger children look Cushingoid and they look like they have steroid toxicity, the cataract part was not common in younger children. But the older children, despite having a shorter duration and cumulative dose of steroid, were more prone to have cataract. So one should screen for cataract and glaucoma in those who are receiving steroids like FRNS and SDNS on a regular basis.
Any effect of changing the type of steroid or changing anything, any effect?
Some of them just change to deflazacort, especially adult nephrologists, they keep changing. But there is, best thing is to use steroid sparing agents. Of course, when you have to induce remission, the fastest way to do it is use steroids. So you use minimum steroids, and as soon as the child goes into remission, you choose one of the alternate immunosuppressive agents. With regard to water intake, sir, I think that was another question you had asked. It's a very, very important point. I would like to highlight here that though the child looks edematous, one may feel that the body is filled with water. There is underlying hypovolemia. It could be a functional hypovolemia, and it's very, very difficult to elicit dehydration signs that is listed by the WHO in another kid with diarrhea in a child with nephrotic syndrome for very obvious reasons of edema. And so dehydration signs may not be easily elicited. And in that case, sometimes the CFT, the capillary filling time is what we look at, because they could be actually requiring fluids and albumin, a colloid like albumin, though they will look edematous. So fluid intake should never be restricted in a child with nephrotic syndrome.
Madam, I think we can answer the question in the chat box.
Sure, I'll do that, sir. Yes. I'm sure these two topics will have many, many questions, and
very interesting.
A whole night answering them. So let's move on to the next topic, urinary tract infection, an equally important condition that pediatricians would encounter. And for this, we have a very dynamic pediatric nephrologist, Dr. Fagun Shah from Surat. He is the pediatric nephrologist consultant at Child's Kidney Care Center, Surat, which is affiliated to major hospitals in Surat. And he's a faculty at various national, state, and regional conferences for both pediatrics and pediatric nephrology, and has organized many conferences in his region. And above all, he's been our pediatric nephrology fellow, trained in our department at St. John's Medical College, and we're always proud of him and his work. So over to you, Dr. Fagun.
So I think I am audible now.
Yes, yes.
Yeah, and the screen is also, seen.
If you could speak a little louder, it's not very clear, Fagun.
Some breaking,
Okay,
some break is
okay.
there. Oh.
Okay, is it okay now?
I think during talking, you stop your video, and then I think there is a connectivity
Okay.
issue there. Then
Okay, I'll stop the
sound
video.
will be clear.
Okay, I'll stop the video.
Still not very clear.
Okay, am I audible now?
Audible,
Okay.
but some breaking, something like that. Okay, we can
Okay,
hear. Okay, continue.
Oh. Okay, so I'll just start my screen share now first.
Voice is breaking, sir. And
Voice
not,
is breaking. Okay, I just try to.
audible.
Okay, I just try to change my this thing, my connection.
What happened, Pagun? Gunsha?
He will come. He will come.
Okay, I am audible now. Hello.
Audible. Continue.
Continue, because that breaking of sound is still there, but I think with the help of a video we can hear. Somebody is saying that you disconnect and rejoin. I don't know how it is
Yeah, I
practical.
think so. Now it will be okay.
Okay.
So I think now it will be okay.
Okay, sir.
Okay.
Please share the
So let me
video.
start my screen share
PPT.
first. Okay. Yeah, so good evening, respected senior fellow colleagues and friends. And at the outset, I would like to thank the organizing committee as well as the IAP Kerala and also all the officers of this very excellent program. It's great to see Dr. Arpana madam also over here, and she has taught me a lot of nephrology, and thank you madam for that kind words of introduction. Well, friends, as we talk about UTI, I am sure that many of you must have heard UTI multiple times in various conferences as well as the CMEs, but the problem is that we are still confused as far as the management of the UTI is concerned. We are confused regarding the diagnosis, number, of the antibiotics, route of the antibiotics, admission criteria, and timing of the investigations. And this is because that we have a lot of guidelines at our disposal. We have the NHS or NICE guidelines, the Indian Academy of Pediatrics guidelines, as well as our own guidelines. And to add on last year, and I think Dr. Arpana madam was also a part of this guidelines committee and also committee of the guidelines for the nephrotic syndrome. So she will definitely be of very help over here. So friends, ultimately, whatever guidelines you use, the main purpose is to prevent over-treatment and over-diagnosis in the patients with the UTI, as well as to prevent much concern regarding the UTI. So it is third, children below 5 years, and a common site of bacterial infection as below that girls outnumber the boys. But the main challenges lie in diagnosing UTI in the instance where there is an increased risk of scarring. Again, as we know that BUR is an important risk factor for the UTI. Prevalence is 30% in the children with the UTI, and overall prevalence is 1% in general population. Say, for example, if you are a population in a city of about 1 crore, then in that instance, about 1 lakh will have BUR, but we will not go on investigating this. And if we take into consideration the renal scarring, about 10 to 15% of the children with febrile UTI will develop scarring. But again, the recurrent UTI will have long-term consequences like renal parenchymal damage, renal scarring leading to proteinuria, hypertension, and ESRD. But again, contrary to our belief, the risk of the ESRD in patients with objective today would be in the management, try to review and understand the newer guidelines and try to look what is new in the offering. So friends, we are so much obsessed regarding the if we see a child who's having a turbid urine or a pyorrhea, we just jump on giving the antibiotics. And it is for this reason that many a times we overtreat the patient. So it is the first important step is to properly diagnose the UTI. So starting with this case, it's a 3-year-old female child and fever for 2 days. This is the only information you have. And the microscopy is showing pus cells is a 10 to 15. So first of all, the question would be that whether these pus cells are significant or not. Many of the times there are many of my friends who keep on calling that I have 5 cells in one of my patients and 8 cells. So whether these pus cells are significant, should I do anything to this? So what is the significant number of percent to qualify as a UTI? More than 10 in the uncentrifuge sample, more than 5 in the centrifuge sample. But then again, the question would be, if these percents are significant, would you like to treat this as a UTI or don't take any action? So everybody would ask me that what are the symptoms and signs and what is the examination? The take-home message is that one cannot diagnose UTI simply by the presence of pus cells, and a complete clinical history and physical examination is a must. Again, this is a 3-year-old child, burning maturation for 3 days, no fever, active and playful. Mother complains that there is a pain and irritation in the vulval region which is persisting throughout the day. The child splashes water to the vulval region to relieve the irritation. So here again we do a microscopy examination because there is a burning. The pus cells are 15 to 20. Again the question would be whether we do treat this patient or not. So again you can see over here that the patient has having a complaint of vulval irritation which is persisting throughout, not only during the maturation, and which is relieved by splashing of water. So it is very, very imperative that you examine the local part and it shows vulvovaginitis. And similar in the males, we can find melanoposthitis which have similar symptoms. So whenever we have symptoms also with pus cells, it is very, very important to have a look at the general or local examination because sometimes we can get a new diagnosis. Now, this is a 3-year-old girl presents with mild fever for 2 days. There is a cough and cold. Another sibling is also has a viable URI. The urine microscopy is again showing 15 to 20 pus cells. So what should we do? Treat the UTI or treat the URI? So again, first instance is that why have we done a urine microscopy over here when the patient is already having a URI? And even if the patient is having a URI, if there are pus cells, we always know that what we have over here. So we definitely need to treat the URI and don't go with the CS. But again, why are these pus cells in the urine? So we need to think about the causes of pyorrhea other than the UTI. So what are the non-UTI causes of pyorrhea? Inflammation in any part of the body, fever, dehydration, any autoimmune conditions, Kawasaki disease, calculi, glomerulonephritis, nephrotic syndrome, and acute inducible nephritis all can lead to a non-UTI pyorrhea, and we need to take into consideration these facts before we treat the patient with the UTI. So this is a 7-year-old boy, recurrent abdominal pain, no urinary complaints, and nothing specific on examination. Normal microscopy, and USG showing normal size kidneys with a thick bladder was suggested of cystitis. Now, our radiological friends are very much fond of giving this sort of information in their USG report of the abdomen. 8 out of 10 USG reports will have this. But again, we have to interpret this in the context of the clinical features, and here there are no clinical features. So this is of the UTI. So this is not a UTI. A word regarding acute cystitis, which is more of a clinical diagnosis with the presence of lower urinary tract symptoms in the form of urgency, frequency, urge incontinence. USG may be subjective, but not diagnostic. And whenever we have bladder wall thickness, it has to be interpreted depending upon the age, what is the bladder filling or emptying, and also it has to be absolute value, that is 3 mm, 7 mm, whatever. So same patient now has a microscopy, but the USG is showing mildly echogenic parenchyma and echogenic debris. So is it the echogenic debris is always a UTI? Because echogenic debris could be because of any cells. It could be because of the RBCs, pus cells, because of the calculi, or because of the crystalluria, because the urine is standing in the bladder for a long time, etc. So it doesn't always equate to the UTI. And again, as far as the mild echogenic parenchyma is concerned, it's very, very subjective finding. And here also you need to extrapolate it depending upon the kidney sizes and other features. So what do? We do treat as a UTI? Definitely not. We would like to know something else. And the other information is that the father has an history of calculi. So this patient on another investigation was found to have a high calcium creatinine ratio. So there was an idiopathic hypercalciuria over here. So the take-home message is from this first report cases are that presence of pus cells always does not implicate that there is a UTI. Proper history and local examination is a must. USG findings with echogenic debris, echogenic parenchyma, and thick bladder wall confuses us, not be a UTI, and the diagnosis is always to be made in context of the clinical scenario. Now again, this is a 2-month-old female child, high-grade fever for 2 days, loose stools and feeding well, no urinary symptoms and no other focus of infection, but there is a history of hydronephrosis endometrically, and currently the left interposterior diameter of the pelvis is 7 mm. Otherwise, the child is non-toxic. So is there a likelihood of UTI? Definitely. A 2-month-old child without any focus and with the hydronephrosis, there could be UTI. So again, what are the symptomatology? And it is very, very important to diagnose the case in the patients who are less than 1 year of the age because of the paucity of the symptoms. The symptoms could be quite vague: fever without focus, irritability, sepsis or poor feeding, cloudy urine, foul-smelling urine, hypothermia, jaundice, unexplained fever, vomiting in the younger children, especially below 1 to 2 years of the age. Though in the older children, that could be dysuria, urgency, frequency, and abdominal or loin pain. And don't forget to do a complete detailed examination. I think everybody is well versed with all the things we need to see apart from the local examination, which sometimes might involve such conditions like labilitation or tight phimosis, which could be a precursors of the UTI. So again, in this patient, the microscope is showing 100 to 150 per cells, urine culture is sent. But I would like to ask again one question. Say, for example, this patient is coming to you at 8:30 p.m. in the evening when you are closing your OPD. So at that point of time, what will you do if you suspect a urine microscopy examination? So you don't, there is no pathologist open to do a microscopy for you. So here the bedside investigation or the office side investigation will come into play. That is, we know the dipstick, leukocyte, estrus, and nitrate. I will not go in much of the details, but these are important investigations which can be done to screen the patient with the UTI. And even the current guidelines now recommend to do this dipstick as a screening investigation. And if possible, you can also go for a microscopy. But the most important thing is that if you are going for a microscopy, the pathologist has to see this urine, within first hour and not late by 4 hours. And if so, then in that instance, you need to refrigerate the urine at 4 degrees centigrade. So again, coming to to this case, whether you need an admission, definitely a 2-month-old child will need an admission. Then the question would be that what are the patients you need to admit? So any patient who is less than 2 months or very toxic patient, not accepting anything orally, and if the patient has any sort of complications, needs to be admitted. What antibiotics? So I would suggest that most of the times you need to have an audit of the sensitivity patterns in your local area, and then you can start your antibiotics. But for all practical purposes, even our guidelines mention, the current guidelines, that you can start with the 3rd generation cephalosporin and definitely by the IV route over here. So again, these are the sensitivity and specificity of various clinical indicators, and you can see leukocyte, estrus, and nitrate have less sensitivity when used alone, but when used in combination has a good sensitivity and specificity, while the bacteriuria has the highest sensitivity and the best specificity over here. And these are the common list of the organisms. Most common is E. coli. We can also see Enterococcus and Klebsiella, Proteus, Pseudomonas, and also Enterobacter as well as the Candida. So what should be the antibiotic consideration? The choice of the empirical antibiotic should depend upon the local sensitivity patterns, and you can have an audit. But our guidelines, recent guidelines mentioned to use 3rd generation cephalosporin or a covamazepine as the initial drug of choice, and it should have a good concentration in blood and renal parenchyma. Again, there is no advantage of multiple over a single antibiotic, and no advantage of parental over oral antibiotic. So if the parental antibiotic is needed and if the patient is admitted, shift to oral sensitive antibiotic as soon as the clinical condition improves, which is within 2 to 4 days. And again, there is a new change over here. So in the current guidelines, in the older guidelines, you must have been, you can just relax that we used to give antibiotics for 10 to 14 days. But the current guidelines mention to give it for 7 to 10 days because various studies have shown that there is no changes in the outcome as far as the radiological outcome or clinical outcome or the bacterial pathological outcome is concerned. So coming back to the case, the child now after 48 hours is afebrile. The urine microscopy is also showing less pulses, but we are getting this culture, Klebsiella plus Staph aureus, and sensitive with all these novel antibiotics. So what are we going to do with this? Is this significant? Definitely not. So how do we consider a normal culture or a culture to be positive? So there should be a growth of single organism in a significant number. So this seems to be more of a contamination. So you won't treat this, but why is this report? So we just investigated and we found that the urine was collected in this bag sample, and the bag sample has a high false positive. It is a good negative predictive value. So if it is negative, it's good. But however, if it is positive, then you can't consider it. And we have other methods like clean catch midstream, which is the most commonly used method. Another includes suprapubic aspiration or the catheterization. So in the children who are not trained or the children who are very sick, you can use the other 2 methods. Again, interpretation of urine CS, everybody is well aware, suprapubic aspiration, any number, usual catheterization more than 10 to the power of 4. But what happens to this midstream? So initially we used to consider the cutoff is 1 lakh. In the latest guidelines, we have shifted to more than 10,000. And why? Because we want to avoid the misdiagnosis in this important age group, especially below 2 years of the age, as found in various studies, which evaluates the urine samples between suprapubic aspiration and the midstream. So nowadays, so in the recent culture, even more than 10,000 is considered a positive report by the clean catch midstream. How do we approach all the patients who are having fever without focus for more than 48 hours, especially in the children below 24 months, and presence of risk factors? And what are the risk factors? Presence of avoiding dysfunction or a ball bladder dysfunction, history of UTI or the history of or there is a presence of reflux. And patients who are having specific urinary symptoms go for a district or other screening test like microscopy and perform a culture. So if the screening test is positive, start empirical antibiotics, and then depending upon the culture reports, you can change it. While if the patient is having a negative screening test, in that instance, just wait for the culture, and if the culture is positive, then you can go ahead. But however, if in the children below 6 months of the age or the risk factors which I just mentioned, if they are present, you need to start with the antibiotics, and then depending upon the culture, you can take a call. So in nutshell, for cystitis in older patients without fever, you need to give oral antibiotics for 3 to 7 days. But if there is a pyelonephritis, you need to admit the children if they are less than 2 months of age, if there are sepsis or if there are complications, and if there is a poor oral intake. But otherwise, you can start with the oral antibiotics. The duration is 7 to 10 days. If you give IV antibiotics, shift to oral antibiotics after 2 to 4 days as soon as the patient stabilizes. But however, if there is no response in next 40 to 72 hours after commencing antibiotics, you have to repeat the urine culture, step up your antibiotics, and also do an ultrasound examination. And so what are the radiological imaging we are going to focus? We have a list of the conditions, but we normally focus on these three, that is the ultrasound, MCUGs, and the DMSA renal scan. So what do we look in the ultrasound? So ultrasound is done in all the patients having the first episode of the UTI, and we like to look at the kidney sizes, laterality, dilatation of the renal pelvis and cancer dilatation, parenchymal thickness, dilatation of the ureters, and the bladder anatomy in detail. But again, after that, whom do we subject to MCUGs or a DMSA? So now we have a major change in the guidelines now. And why this is a change, I will just come to it. So the first episode of the UTI, if the patient, you get an ultrasonography done. If it is abnormal, you do an MCUG, but if it is normal, just follow up this patient. However, if the patient is having a non-E. coli UTI in the children below 2 years of the age, or if there is a recurrent UTI, in that instance, you need to do an USG, but you also have to do an MCUG and see if there is a reflux. And if there is a high-grade reflux that is between grades 3 to 5, you need to do a DMSA after 6 months, not earlier, because if you do earlier, it could be a falsified report because there could be pyelonephritic changes, which later on goes away. So why are we so much restrictive in doing MCUG and DMSA now? The reason is that about 30% of the children have VUR after the first episode of UTI, but just less than 10% of them have high-grade VUR. The others have lower grades of the VUR, which is quite inoculate, and there are less chances of the infection, or there are less chances of the scarring over here. And even though if it is missed by ultrasonography, it is not going to have a more impact. But however, considering recurrent UTI, the risk is 2.7 times in the patients with a high-grade VUR. So all these patients with a recurrent UTI, you need to see whether the child is having a high-grade VUR or not. And hence, we are a little bit more restrictive now in this performing DMSA and MCUG. So now coming to this case, a 1.5-year-old boy, fever for 2 days, active, playful, no focus. But there was a history of UTI 6 months back. So here also there is no focus, fever for 2 days, and there is an history of UTI. So definitely we have to think of UTI over here. First is 80 to 100, culture is sent, and USG which was done 6 months back was negative. So admission, definitely not. The child is active, playful. You can start with oral antibiotics, started with cetirizine, third generation antibiotics, cephalosporin, and the child returns after 48 hours playful. But the culture is showing E. coli, significant colony count, resistant to cetirizine, and sensitive to only IV antibiotics. So what will we do? Change to IV? Definitely not. So there is a lot of difference between in vivo and in vitro sensitivity. And if the patient is responding to antibiotics, definitely there is no need to change. And will you do an MCUG? Definitely yes, because though the USG is normal, but this is the second episode of the UTI. Hence, this child is having a recurrent UTI, and we need to look for the reflux. So this child has completed 10 days of antibiotics, no urinary symptoms, and repeat urine is normal. But I am a little bit more overzealous, and I've just done a urine culture again, which is showing 10,000 colony count of E. coli. So what will we do? Is this colony count significant? Definitely not. The patient is playful, the urine is normal, so we don't need to consider this as significant. So there is no need to change antibiotics if there is a clinical and biochemical response. Document normal urine microscopy after course of antibiotic. While this is not mentioned in our guideline, but basically for my reassurance and also for the reassurance of the parents, I normally do a microscopy after the course of antibiotics, and no urine culture is required after the completion of the antibiotic duration if the child is playful, active, and if the fever is subsided. And this child is having a bilateral grade 3 reflux, and MCUG is done, which is also showing a decreased uptake in the left side and with the lower post scar. So will you start with chemoprophylaxis? Definitely at this point of time, we need to understand that the utility of the chemoprophylaxis depends upon its efficacy to prevent recurrent UTIs, efficacy to prevent renal scarring, and risk of emergence of antibiotic resistance. Many recent trials like PREVENT trials or RIVER trials which were just done have shown the efficacy to prevent recurrent UTIs, but in particular age groups, like for example, patients with DVT or reflux or with the girls. But Again, none of the studies have shown efficacy to prevent renal scarring. In fact, none of the studies have shown that any of the intervention to treat the VUR has any change in the renal scarring. And with the chemoprophylaxis, there is a risk of the emergence of the antibiotic resistance, and hence we have to be very, very cautious. So what is the written guidelines? So for the patients who are having the primary reflux, if there is a low-grade reflux and no UTI, don't do chemoprophylaxis. Even if the child has the first episode of the UTI, you can just wait if the patient is not having any bowel blood dysfunction. But if the patient is having bowel blood dysfunction, you need to start with the chemoprophylaxis. If the patients are having a high-grade reflux, despite of whatever is the status of the bowel blood dysfunction, you need to start chemoprophylaxis. And if the patient is having a breakthrough UTI, despite this, then you need to again go for the reimplantation. And what is the criteria of stopping? Patients who are toilet trained, absence of or BBD has been improved, and there is no febrile UTI in the preceding 1 year. So all these three should be present before you stop the chemoprophylaxis. And these are some of the important points we should consider while giving chemoprophylaxis. It is beneficial in recurrent UTIs with high-grade reflux. Prolonged therapy has a risk of resistance, so you might need to review 6 monthly. Trimethoprim or nitrofurantoin are preferred. And many of the times we have seen patients started on the third generation cephalosporin, which is very, very dangerous. Prevention is always better than cure. Urotherapy, avoidance of constipation, and early treatment are very important. And again, there is a big debate regarding medical or surgical management, and we don't have much of studies to differentiate. So basically, this is a very important Cochrane review which states that the only consistent positive finding is that the incidence of febrile UTI is lower among children undergoing surgical treatment as compared to medical treatment. But however, the studies have not found significant differences in overall incidence of UTI or in nature of new scarring or progression of existing scarring. So none of it is superior, and hence surgical intervention is a reserved modality to be used only in high grades of reflux with recurrent UTIs after chemoprophylaxis, or there are other issues with the chemoprophylaxis after discussion with the parents. And again, open surgery is always better because it gives excellent results. So one again thing to ponder is that do our interventions have any benefit? And there are some facts that renal scarring do occur in subjects without VUR. Again, in patients with high grades of VUR, scarring might be absent. Also in the patients with the pyelonephritis, there is less occurrence of new scars in the kidneys with VUR. And most of the ESRD and transplant registries have not documented reduction in the proportion of the cases of the VUR of the patients with the ESRD despite our intervention. So the ESRD in renal scarring associated with VUR most of the time is predominantly a hypodysplasia. So it is not a scarring, it is a hypodysplasia, while post-infection scars are quite small and innocuous. So what is new over here? And what we can think is that instead of going from a top-down approach, it is basically better to have a risk-based approach in which patients who are having an increased risk of the recurrent UTI, we need to subject them to chemoprophylaxis and surgery. Cranberry juice definitely is helpful, especially in the patients with having a normal tract and recurrent UTI. Management of BBD is very important, and circumcision again is very, very important, especially in the children below 2 years of the age having recurrent UTI and high-grade reflux. What is on the horizon? Steroids. So even these guidelines do mention the steroid, but definitely there is no recommendation of its use because it is still not validated in the pediatric patients. Probiotics definitely in some of the females, there are some of the studies in the females in which it is found that it definitely prevents the colonization of the periuteral flora with the gut flora, and hence it is useful, but no studies in the pediatric patients. And there are vaccines on the horizon like vaccine against T-Mex protein of the E. coli, which is needed for the addition to the bladder mucosa. What to monitor? We all know blood development, blood pressure, renal function. But the important thing is the protein creatinine ratio, and we try to miss this even in our guidelines. So basically, I just want to just narrate this one case was having a high-grade reflux, and the patient was having pre-surgery bilateral cortical scar. Surgery was done because of the recurrent UTI. Everything was fine after that, no UTI. But after 5 years down the line, you can see still there is a deterioration of the function despite no UTI over here. And what was problem over here? There was a hyperfiltration injury and a glomerular loss, which occurs because of the renal scar. So there is a glomerular loss, and hence there is a decreased GFR, and compensatory mechanism to improve the GFR by increasing the glomerular hydrostatic pressure, which can lead to mesenteric injury and glomerulosclerosis, leading to proteinuria, and whole cycle continues leading to the glomerular loss, which could be blocked by AC inhibition. So we need to look at this in all our patients, especially those with the scar. I just will come to this, I think last 1 or 2 cases. 8.5-year-old female child, recurrent UTI, urgency, urge incontinence, and increased frequency with anuresis. Severe constipation impacted stools, otherwise quite normal. And you can see USG, thick wall bladder, and on full bladder it is more than 6 mm, which is quite significant. Full bladder volume is 147 ml, which is less as compared to this stage, and post-wall residue is quite significant. Also, MC, you can see over here there is a tubercular bladder, there is a reflux over here, and also there is a diverticulum. And you can see that the bladder neck is dilated. So this is a case of a voiding dysfunction, and this is basically a bowel bladder dysfunction. High prevalence is found in the patient with the UTI, 41% and 50% with the patient having VUR. Again, high grade of VUR and VBD are independent risk factors, and this causes delayed resolution of the VUR. Again, there is twice the risk of the UTI if the VBD is present in patients with the primary VUR, and failure of strategies to prevent recurrent UTI. And how will you diagnose it? It is very, very important to look at the pointers: constipated stool, impacted stool, maneuvers to postpone voiding. Again, decreased changes in the frequency of the voiding, urgency, dribbling, training or poor stream, thickened bladder wall, and again significant post-void residue and sphincter configuration on the bladder. So basically, what are the variants? Either we have an abnormality of the filling place like overactive retrosor, or abnormality of the evacuation place like dysfunctional voiding or the lazy bladder. The most important are a good voiding diary and ultrasound. Will not be much of the details because this is itself a huge talk. But the most important thing are a good ultrasound and a voiding diary will most of the time tell you what we are dealing with. You can also get an MCUG done and a DMSA. Very rarely we require a uroflowmetry and urodynamic study. And coming to this last case, I think this is a chocolate question, a case. 10-year-old girl, non-specific vulvar agitation, lower abdominal pain, no dysuria, normal microscopy, culture showing more than one colony count, but normal systemic evaluation. Should this be treated? Well, definitely not. This is an asymptomatic bacteriuria. Resolution of the VUR depends upon the grade of reflux, centrality, mode of the presentation, whether it is detected after in enteral hydronephrosis, or in a case of a VPUR sibling screening, or after or it is associated with a DBTs. Again, the resolution rates are about 60 to 70% for grade 1 to 50% for grade 3 and 30% for grade 4 5. And the resolution normally occurs in the grade 1 to by 3 to 4 years, grade 3 by 7 to 8 years, and in grade 4 5 12 to 13 years. So ending my talk, high suspicion, judicious diagnosis, proper cultures, and prompt treatment is the crux of management. Optimization of the treatment and avoid treating overwhelmingly. Careful selection of the patients for the chemoprophylaxis is important. Avoid broad spectrum antibiotics for chemoprophylaxis, and surgery is reserved for recurrent febrile UTI despite chemoprophylaxis in patients with high grades of VUR, but always confirm a normal bladder function, because if the bladder function is inadequate, your surgery is definitely going to fail. So I just end with this slide. Do as much as possible for the patient and as little as possible to the patient. And thank you very much.
Thank you, Fagun. You did an excellent job trying to cover every aspect of the guidelines. And I think you highlighted also the importance of diagnosis of UTI. It's not just like any other infection, because there are serious consequences. And I think that was beautifully shown as to we're concerned about renal scarring, hypertension, kidney injury, and so on. And that's why we are so aggressive about evaluating for the cause of UTI. So I don't see any questions here, but I had one question that came up with regard to nitrite test. So how does that help in your OPD practice? Do you use urine dipsticks to screen for UTI, and what is the utility?
So nitrite test is basically used to, it basically picks up the gram-negative organisms, and it is based on the fundamental of conversion of nitrates to nitrites. So again, as I told you, that a single nitrite test is not very, very important because it has a less sensitivity, but again, it has to be combined with the leukocyte estrus test. But the thing which needs to be taken into consideration, that nitrite test might be false negative in the younger children, infants, because the whole time of the urine in the bladder is very less, because these children tend to void very, very fast. And definitely because of that, you might not get a positive nitrite test. So here comes the importance of the leukocyte estrus test. And if still in doubt, most of the times we go for a urine microscopy. Again, all these group of the patients, especially below 6 months of the age in which the nitrite or other test could be falsely negative. Anyways, if you feel that the patient is having or suspicion of the UTI, because it's a very important age group in which the chances of scarring are very high, so you definitely go for a culture. Then you can start antibiotics, and if the culture is negative, you can stop it. But however, if the culture is positive, then you can continue the duration of the antibiotics.
As such, it is meant for practicing. I am asking 2-3 basic questions. I don't. One is use third generation cephalizin for prophylaxis, but cefixime and cephalizin is well mentioned in standard textbook. Urine prophylaxis, you mentioned not use third generation The second thing is that what about alkalinization urine? A common practice somewhere. This alkalinization urine, people are doing it and the companies are promoting it. Not mentioned. And the third one is that rotating antibiotic prophylaxis, especially for spinomeningomegaly and if a child is getting recurrent UTI and resistant to all organism again and again. What about changing the antibiotics?
I think the first question, Arpana Madam being a part of this guideline committee, and she has seen a lot of studies regarding the use. Even cotrimexazole is basically found to have more of emergence of resistance, and the best is nitrofurantoin. So I think Arpana Madam can answer this first question very nicely, I guess.
Unmute, madam.
No, you're right, sir. If you have access to third generation cephalosporins, you could use it. Only thing that we don't want antibiotic resistance. So that's the main concern nowadays. So there are systematic reviews that are looking at antibiotic resistance versus antibiotic prophylaxis. So the choice of antibiotics also, we would recommend starting with the more basic antibiotics. And if we have any evidence that those are not working, then you would choose the higher antibiotics. Cycling of antibiotics is not recommended in the latest guidelines.
Alkalinization.
Alkalinization. So that's a very common practice. We see most pediatricians doing that. Adult neurologists and nephrologists also do it. So we are just trying to, that is usually used in lower urinary tract infections, which is more common in adults and adolescents with cystitis-like features, and you alkalinize the urine with some citralca and so on. But there is no evidence to use it in pediatric UTI when a child has acute pyelonephritis.
I think as far as this using third generation cephalosporins is concerned, now there are a lot of reviews, not only in the pediatric adults, but also in the pediatric patients, that there is an emergence of the resistance, and sometimes you get the infection by uropathogens, which are extended spectrum metallectamate resistance, and sometimes even metalloproteinase resistance. So it is better to refrain from those antibiotics and use antibiotics which have a high concentration only in the urinary tract, because eventually we want to prevent, because ultimately our infection comes only from the urinary tract. So we just want our chemoprophylactic drugs to have a high concentration in the urinary tract without causing much of the issues in the body. So I think the NFT is considered as one of the best chemoprophylaxis which we can use, followed by trimethoprim.
Madam, one or two messages I'll read for you, madam. What is pelvic calyceal separation, PCS on USG? What is the significance?
So pelvic calyceal separation can be a very normal finding. It's just that the calyceal system and the pelvis are a little separated, which can be a normal finding. So sometimes if there is pelvic junction obstruction, like in PUJs, then that can be prominent. So what we are more concerned is about pelvic calyceal dilatation more than separation, because that gives us a clue that there could be an underlying PUJ obstruction.
One always, all the place, all the people got a confusion about in vivo and vitro sensitivity. It's always a problem because we'll get so many resistant organisms. By the time they report guided, our patient is better and the patient is asymptomatic. So we have to interrupt such a result.
You're asking for antibiotic sensitivity, sir?
Yeah.
Okay. So I think a good example, I think it's important to understand that there's an entity called asymptomatic bacteriuria. I think Fagun had a slide on it. Fagun, if you would like to reinforce the importance of interpreting these urine culture reports.
You want me to just, say about the urine culture? So urine culture, as I told that there are three methods of collecting the urine culture. Either we go for a suprapubic aspiration, or we go for a clean catch midstream sample, which is done in most of the conditions. And third thing is basically we go for a urinary catheterization. So in the children who are not toilet trained, basically we go for the urinary catheterization or the suprapubic aspiration. But in other patients, we can go for a clean catch midstream sample. So again, the number of organisms to diagnose a UTI or confirm a UTI differs upon the type of the collection method. For the suprapubic aspiration, the chances of contamination are almost 0%. So even a single organism can be considered significant. While, however, if the patient is the collection of the urine is done by catheterization, in that instance, you need to have a cut down of about 10 to the power of 4. So more than 10,000. But nowadays, in the third category, so initially we had for the third category more than 1 lakh, and this basically came from the study which was done in 1956 in the pregnant woman. So basically, here it was found that more than 95% of the women who had the cut down of more than 10 to the power of 5 had an infection, and we just missed 5% of the pregnant women. So from there came the cut down of 10 to the power of 5. But again, there are a lot of studies nowadays showing which basically evaluates the urine samples and compare the suprapubic aspiration with the midstream stream catch, that many children between this 10 to the power of 4, that is 10,000 to 1 lakh are missed, and especially these children below 4 are below 2 years. And basically, it is very, very important that we pick up this patient, because otherwise this patient will end up into a renal scarring. So this was this reason that we have come down on the number of the cut down of the number of organisms to diagnose a UTI or confirm a UTI in a clean catch midstream sample. Now, as far as the asymptomatic bacteriuria is concerned, it is, as the name suggests, it is asymptomatic. So it is mainly because of the colonization of the simple or the common cell organisms, which are more commonly found in the females, especially in the older age group. Though in the younger age group, the boys may also be affected. And here there could be a leukocyturia or there could not be a leukocyturia, but otherwise the patients are absolutely fine. There are no symptoms, and also the risk of any renal damage or scarring is almost nil. But however, studies have found that if you treat this asymptomatic bacteriuria, in that instance, the uropathogens, the real uropathogens might invade it and cause a real UTI. So we don't need to touch this asymptomatic bacteria if we are confirmed that that the patient is asymptomatic, there is no fever, and if the microscopy is normal, and even if the microscopy is showing pulses, we can simply wait. So studies have shown that even it can persist up to a year, 2 years, or maybe more than that. So we need to be very cautious again in starting antibiotics, and definitely blanket therapy is not going to help our cause.
Thank you, sir. Thank you very much.
Thank you, sir. If there are no more questions, I thank Dr. Roth and Dr. Shah for this excellent session. And many thanks for having me here, sir. Dr. Jose, Dr. Krishna Mohan, Dr. Paul, Dr. Kesavan, thank you very much.
Thank you very much, madam. Now I invited Dr. Balendran, our national EBM, for concluding remarks. Balendran? Bala? Okay, it was very wonderful session and very eminent young nephrologist from north, east, and also from south also. So we had a wonderful, the first session was a very wonderful scientific feast. And I thank both speakers and also Arpana madam for moderating session. I thank all the seniors and all the IEP office bearers and also our national president, national secretary, and South Zone president, and all other audience who are with us for the last 1.5 hours. Now it is 10:40, so we are thankful to all the audience and all those who attended the program. Thank you. Simipolos, anything add?
Nothing. I think so. Dr. Balachandra is already there.
I was a bit late. Okay, it's okay, sir.
Okay. Thank you. So thank you, madam. Thank you, Fagun.
Thank you, ma'am. Thank you.
Thank you.
Thank
Fagun,
you.
I am from Surat. I called you in the morning. From Surat.
Good night, all of you.
Srinivasan sir, good night.
Yeah, good night, sir.
Sir will be having good morning, I think, sir.
Fagun Shah. Hello?
Yes.
I am studying in Surat only. I am from Surat.
Okay.
Okay, thank you. Good night.
Okay, bye.
Good night, all. Thanks to Kerala IP team once more. Good night.
Good night, madam.